So just simple introduction about the mesothelial or in general mesenteric cyst. The mesothelial cyst is actually underlining of a big hidden called mesenteric cyst. It's a rare intra-abdominal benign tumor. It could happen in 1 per 100,000 case in adult. My voice and screen is clear, isn't it? Hello?
Yes, it's clear. It's clear. Go ahead.
Okay. So it is commonly originate from the small bowel mesentery. Could also happen from the mesentery of the colon, what you call it mesocolon, and could happen sometimes in very difficult case if it is happen retroperitoneum, which is the most complicated scenario of the mesenteric cyst. And the cyst could be classified into cyst of lymphatic origin. It could be mesothelial origin, as in our case, or sometimes from the bowel itself, we call it from enteric origin, or from the bladder, we call it urogenital origin, or dermoid cyst, as in case of teratoma or pseudocyst. And the diagnosis is most of the time is difficult. And most of the time also it is an incorrect diagnosis as a pre-operative. Most of the patients are asymptomatic, but if they have symptoms, they will come, most of them, with abdominal discomfort, sometimes distension in the abdomen, feeling of some heaviness in their abdomen. Some of them, they will come with pain, especially with if it is get complicated. If it's get obstructing the bowel, the patient will come with a nausea, vomiting, constipation, and more than 60% of them, they will complain of abdominal mass, which it will be a clear abdominal mass from the patient and during physical examination. We depend mainly on diagnosis on the ultrasound, CT scan, and MRI. Our aim of this radiological diagnosis to see the size of the mass, location of the mass, surrounding structure and organs, and the nature of the mass, plus the content of the cyst or the mass. Surgery in general is the treatment of choice and should be complete resection, because there is percentage of the patient with incomplete resection and they will come unfortunate with a recurrence. So our case is a young patient also. She is a 31 years female. Medically, she is free. She has 2 kids, and she presented to our clinic, referred from another hospital, complaining of abdominal vague pain, heaviness for about 3 months, with no any other GI symptoms like nausea, vomiting, or symptoms of intestinal obstruction. And there is no previous history of trauma. Sorry, whenever this line coming at the top, my half screen go. I don't know. Before it was okay, but now the black line came. Anyhow, I'll complete. My abdominal examination showed that she has an lower abdominal fondness. We started with our blood investigation, the routine, the complete blood count, the liver panel, renal panel, coagulation profile, all came normal. We did for her tumor markers, with CA99, CA alpha fetoprotein, CA125, all came normal. Patient came with a CD, result of the CT scan from outside, and they reported that she has a large pelvic mass, and they put suspicion of lymphangioma. And the mass was showing a large fluid-filled and multi-septated pelvic cyst. We read the report in our hospital. This is the CT scan patient she presented with. You could, this is the liver, this is the spleen, and you could see this is a small bowel with a contrast, and you could appreciate here is the mass. All this is a cystic mass, which is compressing the small bowel, compressing the urinary bladder. This is a coronal section, and this is a sagittal section, which you could appreciate the cystic mass. We did for the patient an MRI in our hospital, which showed that she has a large non-enhancing fluid intensity area occupying most of the pelvis and the lower abdomen, with a measurement of around. This is the mass. You could see it in one of the view. This is pushing the uterus and this is the rectum. This is the uterus and the bladder. So it's attached closely to the bladder and the part of the uterus. It's almost about 15 centimeter by 40 centimeter, as you could see here in the measurement. The cyst, as I've said, that it's called displacement of the small bowel, displacement of the ovaries, the bladder, some of the pelvic organ, and it is almost separated from the ovary, but attached hardly to the urinary bladder. The fluid inside it, it's not solid component, and they present a lymphangioma with a possibility of omental cyst. This is a T2. You could see the cyst here and how it's pushing the pelvic organ. And this is a T1 with IV contrast. You could see the cyst again, more clear. And this is the bladder and part of the uterus here. So T2 again, homogeneous fluid signal intensity cyst following the contour of the peritoneal cavity, deviating the uterus to the left with no fat content on the fat subbreast image, and no enhancement of the cyst wall or the internal, and there's no internal septation. Apart from small septation, you could see it here, which is more, this is more, this is why the MRI is more specific than the CT scan. It could show the septation inside the cyst. Sorry. The problem there. Anyhow, we decided with this whole picture, we take the patient to the operating room. We explain to her the situation, and after doing all the modalities of diagnosis, and I entered laparoscopic with a 10 millimeter port for the camera, and another 5 millimeter port for the working surgeon port. I found a very large peritoneal cyst. You could say it is multi-lobulated. You could see this is part of the cyst. This is part here, part here, part here. It is close to the bowel. This is another view. You could see the how it's close to the bowel, and it's full with the fluid. And another view here, multi-septated and multi-loculated cystic mass. And this is the attachment of the cyst to the closely to the bladder, with some peritoneal fluid here outside the cyst. So during my laparoscopic exploration, I used the LigaSure. It is a high energy device to separate the cyst from its attachment. Especially, it was hardly attached to the dome of the urinary bladder. But the good news that I was able to separate it from all adjacent structures without any injury to any adjacent structures or organs, especially the urinary bladder and the uterus and the ovaries. So I succeeded to separate the cyst completely. Then after that, because I'm laparoscopic and she's a young lady, so I elected to aspirate all the fluid from the cyst laparoscopically. I sent, sample for cytopathology, and the result came luckily negative for any malignancy. I extracted the cyst completely laparoscopic, and then I extract the cyst through a 10mm trocar. The histopathology after some days came and showed a simple cystic structure lined by a band mesothelial cyst, and they did some markers, the claritinine and the CAM 5.2 plus, with there is no presence of any atabia, and the final diagnosis was consistent with a simple omental mesothelial cyst. This is the histopath picture, which showing a simple omental mesothelial cyst with no any malignancy cell. A patient post-op, after 48 hours, she was doing well. She's recovered so fast. She was happy about the result. She went home safely. With the follow-up, she came after 2 weeks. Then second visit came after 6 months. She was doing well and with no any symptoms. We did for her, but I don't have the result. We did for her ultrasound just to make sure that we didn't left anything and there is no recurrence. And but luckily that there's no recurrence of the cyst. We didn't for her, we haven't done for her a CT scan, because we don't want to expose her to radiation unless there is some question mark of recurrence. So I will just speak shortly about the mesothelial cyst. It is very rare mesenteric cyst of the mesothelial origin. It is the mesenteric cyst actually defined as any cyst located in the mesentery, as I have mentioned before, and could occur in any part of the abdomen from the duodenum down to the rectum. The exact etiology is unidentified yet. There's so many theories about the origin of the mesothelial cyst. It is number one, a growth of congenitally malformed or malpositioned lymphatic tissue. Another theory saying that secondary to a trauma. Another theory it is degenerating of from the lymph node, or most of the accepted theories saying that failure of the leaves of the mesentery to fuse properly during the developmental embryological formation. The etiopathogenesis of the cyst, as we have said, that's unclear. It's a result from congenital insufficient fusion of the mesothelial lined peritoneal surface, or could be from the chronic inflammatory processing triggering a reactive hyperplastic or dysplastic transformation of the mesothelial cyst. Other suggestions saying that there is some neoplastic origin of the peritoneal serous without a strict association with the coexistent chronic inflammatory insult. But this is very, rare if it's happened, and still it is just a theory. The classification of the mesenteric cyst could be classified according to the etiology, classify according to the content of the cyst, classify according to the histological feature of the cyst. According to the classification, according to the etiology, it is either embryonic developmental, or could be due to the trauma, which could be acquired, or could be due to a neoplastic or infective, or could be due to degeneration. I'm trying to find my pointer. Okay. If there is if it will be classified according to the content, it is either serous or chylous or hemorrhagic or chylolymphatic. In our case, it was a serous. That's why it was easy for resection and aspiration. Most of this is, if it is close to the small bowel, or originating from the mesentery of the small bowel, it will be a serous. But if it is originating from the mesocolon, most of it will be a chylous content. The other classification, according to the histopathology, depend on the degree of the cellular growth and atabia. So it could be benign, which is the most common, or malignant, which is the most rare. Location of the mesenteric cyst, as I've said, that it could happen any region in the abdomen or the gastrointestinal tract, from the duodenum down to the rectum. It could happen in any part of the mesentery, omentum, and it's more extension to the retroperitoneal space, which is the most difficult in diagnosis and most difficult in treatment. Most common location, mesentery, mesocolon, bowel omentum. It is distinguished by the presence of the mesothelial cyst lining the inner surface of the cyst. And it could be vary in the size and shape, as in our case. It could vary from few centimeter to a very large one, as in our case, occupying most of the pelvis. The large size, the one which can cause the symptoms, compression symptoms in form of abdominal vague pain or discomfort, or sometimes even patient could present with acute abdomen. In 10% of patients, they could come with acute abdomen. Why they have acute abdomen? Either because of the cyst, it get torsion or valvulus, especially if it is a mobile cyst. Sometimes if the content of the cyst is get infected, patient will come with acute abdomen with a feature of infection, fever, high leukocytosis, and sometimes peritonitis because of the infection. Sometimes the cyst could rupture. If it is supplied with a blood vessel, patient might come with hemorrhage or obstructed uropathy. If it is, obstructing the ureter or part of the urinary bladder, as I've mentioned, patient could come also with peritonitis or small bowel obstruction, which is the most common representation of a patient. If they will have acute abdomen, they will come with bowel obstruction. Mesenteric cyst symptoms, most of the patient has no symptoms. If they will come with the symptoms, most of the time they will come with diffuse, vague abdominal pain, which could occurs in 82%, nausea, vomiting in almost 50% of the patient. Constipation could happen if the cyst is large and causing compression over the bowel, and the patient come with constipation. Diarrhea, and very rare patient could come with the diarrhea. Abdominal mass, as we have mentioned, 60% of patients would come with abdominal mass. The complication, torsion, rupture, hemorrhage, and sometimes could make herniation if there is multi-lobulated cyst and there is a defect in between, so the patient will come with the symptoms of internal hernia and obstruction. As we have mentioned, the cyst, if it's chronic, could turn to malignant transformation in a very rare case. Some literature, it could happen up to 3% of adult cases. The type of the cyst, it is simple, a mesenteric cyst, a simple mesothelial cyst, as in our patient. And it is seen most frequently with a young and middle-aged female patient. It's also, as in our patient, with a good prognosis with the regard of the age, and plus if the patient come earlier in her complaint. Sometimes patient come with more indolent symptoms, and most of the patient will be free of symptoms after a treatment with surgery. Recurrence could happen, but it's very rare if there is complete resection of the cyst. I'll go back to the type of the mesenteric cyst. As I have mentioned, number one is simple mesothelial, which is the most common, and that's in our patient. Number 2, cyst of the lymphatic origin. Number 3, cyst of the bowel origin, of the enteric origin, and it will be most of the time duplicated cyst, and sometimes it can happen from the urogenital, and sometimes it could be mature cystic teratoma, and sometimes we call it dermoid cyst, or pseudocyst, as it happens sometimes with near to the pancreas. It could be either infectious or traumatic. Diagnosis, as we have mentioned, most of the patients are asymptomatic, but occasionally they come with the symptoms of vague abdomen and non-specific abdominal pain. Frequently could discover incidentally in about 40% of the patient. The most used modalities for diagnosis is we started with ultrasound because it's less invasive and no radiation. The ultrasound, you could see like a vascular oval mesenteric mass. The mass could be hypoechoic cystic mass, and you could see a septa inside the mass or debris. Sometimes the mesothelial cyst appear an echoic round mass with acoustic enhancement, especially if there is complication happen. The other modalities of diagnosis is the CT scan. The validity of the CT scan, you could see the size of the cyst, the content of the cyst, if it is a fluid-filled mass, the origination of the cyst, and its relation to the organs and other structures. And sometimes in acute case, the CT scan is helpful in detecting if the cyst is infected or rupture, or if there is internal bleeding. MRI almost same like the CT scan, but it's more specific in diagnosing the nature of the cyst plus the nature of the fluid filling the cyst by using the low T1 signal, high T2 signal. And plus you could see the septation inside the cyst as we've seen it in our case. Despite the previous method of the investigation, the correct pre-operative diagnosis sometimes is difficult and non-correct sometimes, and those findings are unspecific. Other type of mesenteric and omental cysts, such as lymphangioma, may show similar finding. As I have mentioned, patient came with a CT scan from outside with a diagnosis of lymphangioma because it's even radiologically sometimes look like the mesothelial cyst. This is also the case of cystic neoplasm or of peritoneal origins, such as the cystic mesothelioma, cystic teratoma, and cystic spindle cell tumor. Mesothelial cysts are mostly confused with the cystic lymphangioma, as I have mentioned, even happen with our case, though their difference can be mainly you could differentiate it intraoperatively plus by the histopath. In cystic lymphangioma, the histopath result will be positive for the factor 8 and D240, while in mesothelial cyst we will have a positive keratinine, vimentin, and ethidine. So there was some immunohistochemical marker which could differentiate the both entities. We'll come to the end about the treatment option. You could see it even in the literature, the old modalities of treating this patient. It was a drainage, either by the intervention radiologist or by surgical drainage. But this is now out of option because it might cause infection of the cyst, and the recurrence is very high. The second modalities of the treatment is the marsupialization. Also now this modalities of treatment is out of choice, but could be used only if it is multiple, if the cyst is hardly and closely attached to the very vital organs and you cannot separate it. So you are elected only to do marsupialization. And also in some situation, the cyst could be retroperitoneum. So it's very difficult to go down to the retroperitoneum and to excise it completely. So the only way that you open it, you evacuate all the fluid, then you marsupialize the edge of the cyst just to prevent of reaccumulate. But still the chance of recurrence with marsupialization is there. The other option is inoculation. It is also rare to be done right now. The most common now and the treatment of choice is the complete surgical resection. The complete surgical section, as I have mentioned, is the treatment of choice. It could be either complete excision of the it's offer a complete excision of the cyst. It has also very low recurrence rate, and it could be done either open surgery, but we don't recommend it. And it could happen, it could also done laparoscopic, especially if you have a high skilled surgeon could do it in laparoscopic with the minimal invasive small holes, especially as we have mentioned that most of the patient, the young female patient. Sometimes with a difficult cyst, you elected to resect some adjacent structure, but this is very rare if it's happened. In my conclusion, mesenteric cyst is a rare intra-abdominal tumor present with a varied and non-specific symptoms. It must be considered in the differential diagnosis of a cystic lesion within the abdominal cavity. The ultrasonography, the computed tomography, I mean the CT scan, MRI, are the most useful imaging modalities to diagnose mesenteric cyst in general, and the mesothelial cyst as in our case in a specific. Complete surgical excision is the treatment of choice. It is associated with a good prognosis and low recurrence rate. Thank you. This is the end of my talk. And special thank to everyone with us now online. Special thank to Miss Augusta and all of you. Thank you and have a good day.